everyone, myself Dr. Priyanka and I'm one of your mentors for study MRCPI. So today we are back with the YouTube series and today we'll be discussing on the labor and delivery module and we'll be discussing the important questions with the single best answers. So do like, share and subscribe to Study Medic channel and also press the bell button icon. So here the quote of the day today is a little progress each day adds up to big results. So always keep practicing, continue your efforts and definitely you will shine. Now coming to the questions. So she is a 34-year-old primary gravida who is in spontaneous labor at 39 weeks of gestation. Okay, so she is full term and at 39 weeks she is in spontaneous labor. She had rupture of membranes. The liquor is clear. Fetal heart rate is reassuring. She is having one contraction in 10 minutes, so which is lasting for 15 seconds. And a decision is made to start her on oxytocin because she is having big contractions. Which of the following is not an absolute contraindication to oxytocin? So she is otherwise low risk. She is 39 weeks full term and she had spontaneous rupture of membranes. The fetal heart rate CTG is normal, but she is having big contractions and we now want to start her on oxytocin. So what are the what are the which is not an absolute contraindication? So others are complete absolute contraindications, but we have to select which is not. Okay. So non-reassuring fetal testing is an absolute contraindication where we are not going to start oxytocin because we know that oxytocin can also lead to fetal heart rate abnormalities because of the tachysystole or hyperstimulation it can cause and hence lead to non-reassuring CTG. So if the already it is non-reassuring, we are not going to avoid oxytocin. If there is a tachysystole of the uterus, so there is no point in giving oxytocin because we need to give medications which will decrease the contractions like terbutaline. So that is also an absolute contraindication. Then the option C is previous scar on the body of uterus or a previous uterine perforation, classical section or a myomectomy. So here in this also, these are the women who are at high risk of having uterine rupture. So in these patients, the main option, correct delivery mode is to have an elective cesarean section. And those who are having transverse or oblique lie of the fetus, in them also the best method to deliver is to having an elective cesarean in transverse or oblique lie because there is increased risk of cord prolapse also in these patients. So here the best option, which is not an absolute contraindication, is a woman who is in preterm labor. So because in preterm patients, we can start oxytocin, that is not an absolute contraindication. So the answer is here is option D. So let's see what are the absolute contraindications. Absolute ones are the ones who are having non-reassuring fetal testing, tachysystole of the uterus, if there is a previous classical section or a previous uterine perforation, if there is an transverse or an oblique lie, and malpresentations such as space, grow, and breach. So these are the absolute ones. And these are the ones where we will give oxytocin, but we will be giving with caution, additional caution, definitely. So who are these? So these are the women who had previous ones low transverse scar. Okay, previously one cesarean but a low transverse incision that was, and we are going to judiciously monitor the oxytocin dose and monitor the labor provided. Okay, in them we can consider giving using with caution. In those women who are multiparous or a grand multiparous woman, because there is increased risk of tachysystole or a hyperstimulation in them and also increased risk of uterine rupture, especially in multiparous women because of oxytocin. So we are going to give with caution. In women with preterm labor also we give with caution, and in women with those having myocardial ischemia or a cardiovascular disease, because oxytocin will cause contractions and can cause uh, uh, during the contraction we know there is decrease in the blood supply, so that changes in the blood pressure and heart rate we want to avoid. And in women with the long QT interval, so the oxytocin has a side effect that it prolongs QT interval. So in those who already have long QT interval, so it is used in caution. Now here is a 25-year-old woman who is grounded to paravan and she is 26 weeks and had come with reduced fetal movements which were present for almost 3 days. So she had a previous normal vaginal delivery 3 years ago. And now on examination, her observations are normal. There is no bleeding or no leaking vaginum, and the ultrasound shows that there is intrauterine death of the fetus. And a decision is made to induce her labor. So, what is the most appropriate management option here? It is to, because she is 26 weeks, we need to refer to the FIGO guideline. So here we need to give mifepristone first. That is the option correct is here is uh, number 3. We give mifepristone 200 mg per oral, wait for 1 to 2 days, and then we start misoprostol 200 micrograms every 4 hourly until expulsion. So always remember the as the gestation advances, the dose of misoprostol decreases. So the answer here correct is answer C. So now coming, if you look here, so if she is between divided, the dose is divided according to what period of gestation the patient is, and also if they had induced abortion or a fetal demise, or they are going to have an induction of labor. So if she is between 26 or 27 weeks and she had a fetal demise, so she will have a mifepristone first, and then followed by that a misoprostol 200 micrograms every 4 hourly until expulsion. So that's the correct answer. Now there is Mrs. S who is pregnant with 38 weeks for the second time. This pregnancy was smooth with no risk factors, and she was induced in her first pregnancy, but she had bad experience that time. So she is in her second pregnancy and she is low risk otherwise in her second pregnancy, and because in her first pregnancy she had bad experience, so she wants to take advice from you that this time what she can do. So what is the best option for this patient if she is low risk is the answer is answer number 1, that is to wait for spontaneous labor and deliver her at low risk midwife unit because she is low risk. So now there is a 28-year-old woman who is primary with a BMI of 38. So she is with a high BMI at 39 weeks, and she has come in spontaneous labor. So when it was 7 a.m., so she was 4 centimeters, cervix was 4 centimeters dilated. And after 4 hours, that is at 11 a.m., the cervix was found to be 9 centimeters dilated. And after 2 hours, that is at 1 p.m., it was found to be fully dilated. But the position was found to be occipito-posterior. So there is malposition. So what is the most appropriate next step in the management? Okay. So currently looking at the scenario, you can see that even if she has a high BMI, but she is progressing well. Okay, so and within the normal range. So she has progressed till now, but it is that the position is fetal head position is it is occipital posterior. There is malposition. So we can exclude the options that are you going to do a category 1 cesarean that is an urgent, is there any urgent indication for a cesarean? So it is not the answer. Not even a category 2 cesarean because the rest of the things they have written are normal. Fetal blood sampling is not done anymore. And then operative vaginal delivery. Or is there any need of an urgency here right now? Is not, because it is just 1 hour that but like she can wait for 1 hour. We can wait for one more hour, and then we can reassess her if there is any imminent delivery happening or not. So most appropriate next step is to the answer is E, reassess after 1 hour. Why? So this is from the NICE guideline. So if they are in the second stage of labor and if all the observations are normal, then we can do half hourly documentation of frequency of contractions, hourly blood pressure, 4 hourly temperature, and frequency of passing urine, and we can offer them a vaginal, that is, we do a reassessment after 1 hour in the active second stage. So that's the answer. Now you are working in the obstetric unit with level 2, okay, level 2 neonatal care facilities. And there is a primary gravida who has come at 32 weeks with small painful contractions. And also she has PPRM, that is premature pre-labor rupture of membranes. She is pyrexial and has a temperature of 38 degrees and a pulse of 108 per minute. The CTG confirms regular contractions and there is fetal tachycardia of 170 with good variability. A speculum examination was done and the cervix was shown to be 2 to 3 centimeters dilated. This patient had come 2 weeks before because again she had a history of threatened preterm labor and she had received 2 doses of steroids, that is dexamethasone. So what's the most appropriate management in her case? Okay. So she's 32 weeks, but looking at, and she has come to the level 2 care, but looking at the clinical scenario, has come with PPRM, but she has clinically signs of chorioamnionitis, the maternal and fetal signs, because there is fever, there is tachycardia, there is fetal tachycardia with maternal tachycardia, but the variability is good, and the cervix is found to be 2 to 3 centimeters. So what's the best option is to commence the antibiotics, but after doing the septic screen, and allow the labor to continue with continuous electronic fetal monitoring and informing the neonatal unit. So why the correct answer is A? Because she is 32 weeks pregnant. So a level 2 care can also be able to manage this patient. Okay, at 32 weeks. But here so answer B is wrong. There is no need for an in utero transfer. She can deliver in a in utero at level deliver in a level 2 care. Are we going the answer C, that is commence tocolysis? We are not going to do any tocolysis because she is already 2 to 3 centimeters and she has signs of chorioamnionitis which needs because she needs to be delivered, and she has the main aim of giving tocolysis in nowadays is to for the steroids to act and do the in utero transfer. So here tocolysis is also not the option. So answer C is also incorrect. She has received steroids. Answer D is we do not give second dose of steroids again. We do not give repeat courses if we have already given. So repeat dexamethasone tocolysis is also not a correct answer. Even repeat dexamethasone antibiotics is and doing an emergency cesarean is not a correct answer because there is a good variability. So answer here is answer A, that is giving antibiotics after septic ring and allowing the labor to continue with continuous electronic fetal heart rate monitoring. So, the conditions that may be associated with reduced perception of fetal movements include all except. So, which of the following conditions are associated with reduced fetal movements except? So, when the fetus is sleeping, in that time, during that time, also the movements are less. There is maternal perception are less during fetal sleep. During fetal anemia also in that also there is reduced perception of fetal movements. In BMI, those who have a high BMI, they also have been found to have, especially if it is more than 30, there is reduced perception of fetal movements. Even in smoking, that smoking also it decreases the perception of fetal movements. Whereas primiparous women are more prone to have reduced perception of fetal movements than the multiparous woman. So here the answer correct is answer C. So there are factors, the fetal factor, maternal factors, and other factors which are responsible for reduced perception. If there is fetal factors, what are those? Like fetal death, where the baby is not going to move, fetal sleep, fetal anemia. So, and also fetal growth restriction, especially. And if fetal growth restriction is associated with decreased fetal movements, there is increased risk of poor adverse outcomes. Also, if there are some congenital anomalies like skeletal, musculoskeletal anomalies, that also will lead to decreased fetal movements. And maternal factors like busy women, so they may not be able to pursue as much movements, especially when they are compared to when they are there is a quiet environment, or when they are uh, like when they are concentrating on the movements. So if they are busy, the movements are less. The smoking also will decrease the perception. In primiparous women, there is decrease, not in multiparous. And if the BMI is more than 30, that has also been found. And some medications will also decrease, some sedating agents or benzodiazepines, narcotics can also reduce the perception of fetal movements. And the other factors are when there is either low or increased amniotic fluid volume, so the mother won't be able to pursue the movements. Okay? And if there is an anterior placenta, so if there is a placenta so the perception between which is present between the fetus, so the perception will be less. Thank you everyone for attending. I hope this helps. Thank you so much.